Hi, good morning, everyone. I'm Vincenza Di Stefano from the Italian National Institute of Health. Today, I will present a data review from the EU survey on policies and programs on childhood obesity and responsive parenthood in the context of the joint action Health4EUkids. This survey was conducted by the Italian National Institute of Health as part of the activities of Work Package for Transferability and Sustainability, which it coordinates for Italy. As we unfortunately know, overweight and obesity are growing public health challenges worldwide, especially among children. Their prevalence has been increasing with serious health consequences linked to increased risks of cardiovascular disease, type 2 diabetes, and cancers. This urgent issue calls for coordinated action across countries to ensure a healthier future for the next generations. This survey aimed to describe the state of art of policies and programs on obesity prevention for children aged 0 to 12, health promotion, and responsive parenthood in the EU. We conducted a cross-sectional study using an online survey as part of the Health4EUkids joint action activities, which took place from October to December 2023, and it involved all EU joint action member states. And one or more respondents answered the survey for each country. Here in this slide, we can see an overview of the EU policies and programs collected. The survey collected information about 79 policies and programs from 12 member countries involved in the joint action: Belgium, Croatia, Finland, Greece, Hungary, Italy, Lithuania, Malta, Poland, Portugal, Slovenia, and Spain. The data collected covers both national and subnational levels, but the level of policies and programs described has been predominantly national. The main sectors covered by policies and programs are healthcare, followed by the educational and social sector, with a target focusing on children aged 6-11 years group. The settings of policies and programs included primary school, followed by community, secondary school, community health services, preschool, municipalities and hospitals, and workplace. We have some missing data for some reasons, such as respondents might have forgotten to include it. Some policies could be under review or being written. Respondents not know about those specific policies. Here we can see that the policies and programs are characterized by different degrees of innovation, controversy, transferability, and sustainability, although the structural or systemic impact, the equity dimension, and the public visibility appear to be lower among other characteristics. Now, the formulation and design of public programs included problem analysis based on national or local data and based on stakeholder consultation. Regarding the types of stakeholders involved in the planning process, the primary stakeholders involved include scientific society, followed by community association, the general public, third sector, and NGOs. About 22% reported other stakeholders involved in comments, such as school and educational stakeholders, food producer, or the agriculture sector, politicians, or independent experts. Now, an overview of the implementation characteristics of the policies and programs collected is shown here. As for the implementation, most policies and programs are implemented upon release, but recommended action and allocated human resources are not fully adequate. Regarding monitoring and evaluation policies and programs were defined by a set of outcomes, standard indicators, which are measured on a regular monitoring basis. Regarding the dissemination of policies and programs collected, the results of the implementation process are communicated to decision makers and stakeholders in 42.7% of cases, and they are communicated through the media and to the general population in about 36.8%. Finally, in this survey, we also asked through open-ended questions to identify the strengths and facilitators and the weaknesses and the barriers of the policies and programs. Regarding the strengths and facilitators, the policies are supported by evidence and the integrated approaches to a promotion. Case strengths include collaboration among specialists and inclusion of comprehensive health aspects like physical activity and mental well-being, in the integration across sectors and quality professional training could enhance the effectiveness of these programs. Regarding the weaknesses and barriers, the main weaknesses include limited resources and financial constraints, which reduce the program's effectiveness and sustainability. Other barriers include insufficient data updates, lack of regional implementation, and a low cultural sensitivity. Success often depends on motivated individuals, making long-term engagement challenging. So to conclude, most policies and programs, especially in healthcare, are variable and context-dependent. It is necessary to align the policies with implementation in all its aspects and to reinforce monitoring, evaluation, and communication with the relevant stakeholders. Additionally, the study emphasized the importance of aligned policy formulation and implementation to increase the effectiveness of EU children's health policies and programs. So what was the next step of this study? The identification of gaps in the policies and programs then supported the development of the DELTA process and of the policies brief, which are part of the activities of the joint Action Health4EUkids. And that's all. Thank you all for your participation, and bye-bye.